I would prefer to finish our topics today afternoon, but I still think we should be able to finish before 4:30. So what we're going to talk about is control of respiration. And you have looked at respiration after I introduced it for you a couple of weeks ago, that respiration are all those processes that enable us to absorb oxygen for utilization by the body and then also to release carbon dioxide. And we looked at the ventilation, blood gas, diffusion before that, then blood gas transport, and then diffusion again to the tissues. Now, the question is, how does the body control respiration? And this, first of all, you have to understand what is the body trying to control when we talk about control of respiration. And the purpose or the aim of control is to maintain the arterial level of oxygen, so partial pressure of oxygen in the arteries, that's why it's called PaO2, and then the partial pressure of carbon dioxide in the arteries, and to some extent, the pH. That comes a distant third. The main aim or the prime purpose is to control oxygen and also the carbon dioxide. Now, we looked at those four processes. Now, what is important for you to understand is that in all these processes, if you look at blood gas diffusion, it is basically physics. As long as there is enough partial pressure of the gas on one side as compared to the other, diffusion will take place according to Fick's law of diffusion. Gas transport, you'll see that it was largely the responsible of the cardiovascular and the hemopoietic system. So as long as there is hemoglobin, cardiovascular system is pumping the blood, gases will get transported. So our respiratory system generally is not regarded as having the ability to control either diffusion or gas transport, and indeed the tissue gas diffusion. Again, that is pure physics. So the only part of respiration that is controlled is actually ventilation, directly by the respiratory system. And often we say that the control of ventilation is almost equivalent to the control of respiration. But we must realize that there are other systems involved in controlling the other factors. But when we talk about control of respiration, we largely talk about the control of ventilation. Now, this diagram you will remember from your first years. This kind of diagram is our control model, which is very important for us to understand. This is our classical feedback loop, where our respiratory system is the system being controlled, and the controlled variables are oxygen, carbon dioxide levels in the arteries, and as I mentioned to you, pH, which we will cover in due course. There are controllers which can affect the respiratory system that will lead to the different levels of oxygen, carbon dioxide, and carbon dioxide and oxygen can then be detected by sensors, which will give that information back to the controller. We also have this loop, which you'll remember is your feed-forward loop. The feed-forward loop may detect other influences that may either be helpful to the respiratory system or detrimental to the respiratory system. And that would be again fed forward to the controller, which can then issue forcing functions to preempt any changes of the oxygen and carbon dioxide levels. So remember the feedback loop and the feed-forward loop. Another way to look at it is to put names to those different components. Our controller generally are the highest and is the respiratory center, which I will discuss in detail. The respiratory center has neural output to the ventilatory apparatus, so that the respiratory center can affect ventilation, either cause inspiration or expiration. It can increase the rate and depth of ventilation. So that is the controlling influence or the forcing function. Then we have many types of receptors. You will see that we have chemoreceptors, which will detect the levels of the gases. We even have stretch receptors, and we will also see other receptors. And some of the extra influences that can come to the respiratory center are influences from the higher center, which we will also cover. So this puts names to the particular components of the control model. So let us then start by looking at the controller, which is the so-called respiratory center. The respiratory center is in the brainstem. And in the brainstem, there are structures which, when stimulated in experimental animals, cause certain effects. So because of that kind of experimentation, those centers have been called various controllers of respiration. So if you start by the lower one, which is in the medulla, you have groups of neurons, which are called the dorsal group and the ventral group. Then if you go a bit higher, in the lower pons, you have a group called the apneustic center group of neurons. And finally, you have the upper pons group. And all of these have different effects on the respiration. So if I would to just delineate that, the medullary respiratory center, if you stimulate the dorsal one, it largely is inspiratory. The dorsal groups are inspiratory, and the ventral groups are largely expiratory. Yeah, so those are easily remembered by the acronym DIVE, DIVE, dorsal inspiratory, ventral expiratory. Yeah? I just show you this diagram again. So dorsal group here and ventral group on the sides. Sorry. And then the pontine in the upper pons, that is called the pneumotaxic respiratory group. And this pneumotaxic is the same root of word that from the word taxi comes, though it means to increase. So the upper pontine group helps to fine-tune respiration. Initially, it was thought it just increases the rate, but now it is thought that it actually fine-tunes the respiratory rhythm. And finally, you have the apneustic center in the lower pons, which helps to prolong the inspiratory potential. So just please don't forget these. I want to show you the diagram again. So dorsal and ventral group, the apneustic center, and the pneumotaxic center in the upper pons. If you look at the discharges from these neurons during inspiration and expiration, this is just a diagram showing the tidal volume in and out of the lungs. You'll find that the dorsal group, which is inspiratory, is a rapid positive feedback mechanism. You can see this, the graph of this curve becomes increasingly steep. So as one fires, more and more neurons fire until you get maximum inspiration. And then you have a cutoff. Remember, there's no positive feedback without a cutoff. You get a cutoff, and then there is a rest where the dorsal group is inactive. And if you recall, at rest, expiration is passive. So there's passive expiration due to recoil of the chest and abdominal structures, including the diaphragm, and then the same cycle starts again. So at rest, the neurons that are basically active are the dorsal inspiratory group. This is further shown in this little flow diagram, where during inhalation, the dorsal group is active, the inspiratory muscles contract, inspiration occurs, then the dorsal group is inhibited. In fact, it is cut off, and I will mention later on how it is cut off. The inspiratory muscles relax, passive expirations occur, and then the cycle plays again and again throughout life. That is quiet breathing, breathing at rest. But if it is forced breathing, when we are exercising, when we have to provide more oxygen to the tissues, then during inspiration, the expiratory center, of course, is inhibited. The dorsal group is active. Inspiratory muscles contract. Inspiration occurs. And then not only are the dorsal group inhibited, but now in forced expiration or forced breathing, the expiration is active so that the expiratory center is also stimulated, thereby forcefully removing the air from the lungs. So you have active expiration. That's the difference between quiet inspiration and forced breathing, yeah? Where you have, in forced breathing, you have the expiratory neurons and the expiratory muscles also getting activated. This basic rhythm of breathing is influenced by a number of factors. And first of all, can be modified by central command, by the central or the higher centers. For example, when we speak, when we are playing musical instruments which require breathing, all of that requires our breathing to be controlled. So we use our expiration for breathing. So we have to take a breath and then speak. Yeah, we can't speak endlessly. So that has to be voluntarily controlled. But there's also involuntary control. For example, when someone is angry, or his or her breathing will rise both the depth and the rate. Whereas if someone is fearful, the breathing actually becomes both shallower and slower. We can, of course, hyper or hypoventilate voluntarily. Yeah, I can sit here and breathe, hyperventilate, or I can even hold my breath, yeah, or hypoventilate. So, but all of those have a involuntary override. You can't hold your breath and kill yourself, for example. Yeah, you have what is called a breaking point. We will come to how that breaking point is reached in due course. We will come to this chemical control later on. Just leave that for a second, please. So here it is that we have, not only do we have these higher centers where we have speech and emotion and voluntary control of breathing, but there are other receptors which influence. Number one, the stretch receptors in the lungs, they inform the medulla of the relative stretching of the lung and the chest. And that is one of the primary reflexes that allows the inspiratory potentials to get cut off. In addition, we also have proper receptors in muscles and joints, so that when someone is, for example, beginning to run, just as the first few fast steps that you take for running, immediately the respiratory center is informed that the demand of oxygen may rise, so that immediately our breathing rate rises. Pain causes a sharp pain, not only physical pain, but even temperature. Excessive cold causes a sharp input of respiration, and you in fact hold your breath. All these are involuntary reflexes which are initiated by receptors outside the lungs. Yeah, the proprioceptors and the pain and touch and heat receptors. We are going to look at the effects of the chemical receptors next, which is actually the crux of the matter. All these others are adjuvant receptors. The main control of respiration is through the chemical receptors. And the chemical senses, there are divided into the peripheral receptors and the central chemoreceptors. The peripheral chemoreceptors are located in the arch of the aorta and right at the bifurcation of the common carotid artery. And there are small dilatations of the arterial vessel wall, which are called carotid and aortic bodies, respectively. These carotid and aortic bodies have a mechanism for detecting the level of oxygen. They actually have receptors that combine with oxygen, and this causes certain potassium channels closure to occur and causing depolarization of the receptors, and then the action potential in the nerves. And these nerves, as you can see, from the aorta, it is the vagus nerve, and from the carotid, it is the glossopharyngeal nerve. This primarily detect oxygen, but not exclusively. You can see that as the arterial level of oxygen falls on this graph, there is a certain point, and that point is usually 60 to 65 millimeters of mercury. That point is when the receptors actually discharge exponentially. But of course, as soon as it starts falling below our normal, as you know, is about 95 to 100 millimeters of mercury in the arteries of oxygen, then there is the response. Any degree of hypoxia results in the discharge from the aortic and carotid bodies. Yeah? We can leave this other graph for the time being. We will come to carbon dioxide in a few minutes. The central chemoreceptors are located in the brainstem, and these chemoreceptors do not directly measure carbon dioxide or oxygen, but they actually measure it indirectly. And the way this works is as follows: that if this is our brain, this is the cerebrospinal fluid, and this is a blood vessel. H plus ion cannot penetrate the blood-brain barrier, but carbon dioxide, being much more soluble, can diffuse across, as can oxygen. But carbon dioxide then is changed by carbonic anhydrase. There's a special extracellular carbonic anhydrase, which is in cerebrospinal fluid, which converts this to carbonic acid. Carbonic acid then splits to H plus and bicarbonate. And it is this H plus which goes and stimulates the central chemoreceptor. And as you know, carbon dioxide and H plus are in equilibrium. So that H plus is not only a measure of the pH of the blood indirectly, but it's also a measure of carbon dioxide. And the answer to the question that beckons is that, are the central chemoreceptors sensitive to oxygen? Of course they are. Yeah, they have to be. But this is a special way in which they detect carbon dioxide and pH indirectly. Okay. So we were mentioning other reflexes. So remember where we are. We are looking at the various sensors that affect the control of the basic pattern of respiration. We have looked at the receptors, which are divided into peripheral and central, and we are just going into some more detail about various reflexes. This Herring-Breuer reflex is the reflex which is basically the stretch reflex of the lungs, and it limits the degree of inspiration. So when the lungs are getting inflated during inspiration, that gives the information to the respiratory control center that the lungs are indeed getting full. This allows, at a certain point, the inspiratory impulses to get cut off. So although we are not very sure what role it plays in the adult, but it certainly helps over inflation of lungs. Yeah. There are other receptors which affect respiration. We have already mentioned pain and temperature, and we have also mentioned the proprioceptors, but there are mechanical and chemical irritation receptors in the nose and the upper airway that, for example, make us sneeze. Sneezing involves a sudden, strong expiration, and this is usually from irritation in the upper airway and helps to expel usually physical irritants from the upper airway. Coughing, similarly, is a reflex of a similar kind in the lower respiratory tract, which allows material to be expelled. So that in a cough, basically you increase the pressure in the lungs by closing the glottis, and then there's a sudden opening of the glottis, which allows that material to be expelled. Atrial stretch receptors may influence the respiration to some extent, but they are not so important in contributing to the rhythm. So, right. So now where we are, we have looked at the overall control of the respiratory system, and I've told you largely the control is dependent on the control of ventilation, because the other steps of respiration are not directly controlled by the respiratory system itself. So we have looked at the controller, the respiratory center. We have looked at what it can control. It's simply controlling the rate and depth of respiration. And either it is increasing or reducing the rate or depth of inspiration and expiration. And we also have looked at the various receptors that feed information to the central controller. The most important of these are the chemoreceptors. Chemoreceptors, peripheral chemoreceptors detect mainly oxygen, to some extent carbon dioxide, and to some extent pH. Central chemoreceptors detect pH, but indirectly. They are also sensitive to oxygen, and they detect carbon dioxide indirectly, the way I mentioned to you. And then we looked at other receptors. Now, proprioceptors, remember, are feed-forward receptors. They tell the body of the need for higher respiration, for example, when one is running, and then that would help sort of preempt the need for more oxygen. We are now going to look at some responses that sort of puts everything together and gives you more detail about the relationship between oxygen, carbon dioxide, and pH control. Right, this is just to remind you that this is our feedback loops, which are classically happening in the chemoreceptor system. These are our feed-forward loops, yeah, so that when we're about to run, the proprioceptors, or even before the thinking of exercise may increase your respiratory rate. All of that is feed forward. So the relationship between the gases that are being controlled and what happens to respiration should be very clearly understood. So if this is alveolar ventilation, you can see that when carbon dioxide is at its normal level, and you know, in the arterial blood, the normal level of carbon dioxide is 40 millimeters of mercury, then the respiratory ventilation is at a basal rate, yeah, at a normal rate, which we discussed when we looked at ventilation. But as soon as the PCO2 rises, there is a corresponding rise in the ventilation. And the purpose of that, obviously, is that if there is a high carbon dioxide, immediately it will be removed from the lung so that we do not accumulate carbon dioxide. Yeah. Similarly, if you look at pH, the normal pH, here, look at the pH scale is the other way around. So we are becoming more acidic as we go from left to right. So the normal pH is about 7.40 in the arterial blood. You find that as the pH falls, then there's a steady rise in the respiration. And that also, what will that achieve? That will achieve removal of carbon dioxide. As I told you, carbon dioxide and H plus are in equilibrium. So when you lose carbon dioxide, you are in fact losing acid. Not only are you losing carbon dioxide, but you're in effect removing acid from the body. Any loss of carbon dioxide is the loss of acid. So fall in pH, rise in carbon dioxide causes increase in ventilation. This is the effect of ventilation on blood gases. And this is looking at it from another perspective, that If one is just ventilating at the normal rate, you find here is your carbon dioxide at 40 and your oxygen at 95 millimeters of mercury plus. If one hypoventilates, means you ventilate less than required, immediately your oxygen levels start falling and your carbon dioxide levels start rising. If, however, you hyperventilate, if one hyperventilates, two things happen. There is a slight increase in the oxygen, not so much. Yeah, because it's already, the hemoglobin is already maximally saturated. The only thing hyperventilation actually achieves is that if at the same time the cardiovascular system is also pumping faster, then more oxygen can be delivered. So hyperventilation alone cannot deliver more oxygen to the tissues. So if one hyperventilates, yes, there's a slight increase in the respiratory rate, in the oxygen levels. But what is striking is that the level of carbon dioxide falls. So hyperventilation actually throws out too much carbon dioxide. And this is actually loss of acid. And we shall see later when we do acid-base balance that actually that can result in a state of alkalosis of the body. Okay. Carbon dioxide and oxygen affect each other so that if pulmonary ventilation, if you look at, this is a graph of ventilation with alveolar carbon dioxide. So let's look at when the oxygen is 110, and you find that, yes, it is proportional. But if the oxygen is lower, you find the effect of carbon dioxide is potentiated. So that if there is pre-existing hypoxia, the effect of hypercapnia on ventilation is heightened. Yeah, so that they work hand in hand. Both a low oxygen and a high carbon dioxide are strong stimulants for respiration. Similarly, if the oxygen, if you look at oxygen, so that here is our oxygen curve, that the lower the oxygen, higher the ventilation. If carbon dioxide is higher, it also potentiates the effect of hypoxia. So both of them influence each other positively so that the effect of a rise in carbon dioxide is similar to the effect of a fall in oxygen. And they potentiate each other so that the body has the ability to offset hypoxia and hypercapnia together. These two facts give rise to a very important concept, which we call the hypercapnic ventilatory drive and the hypoxic ventilatory drive. All it means is that carbon dioxide stimulates respiration. So hypercapnic ventilatory drive means that any rise in carbon dioxide results in a rise in ventilation. And that, in fact, during rest, when we are at rest, it has been shown that it is the hypercapnic ventilatory drive which controls our rate of respiration. And why is that? It's like that because the hypoxic ventilatory drive, my friend, is very powerful, very sensitive. It never in health allows oxygen to go below 90 millimeters of mercury. Our drive for hypoxic ventilatory drive is too accurate. Any small fluctuation, it immediately corrects it and does not allow oxygen to fall. After all, that is the most vital requirement for our life processes, oxygen. We cannot live without oxygen more than 4 minutes, as you well know. So at rest, our oxygen is so tightly controlled that it cannot influence the second to second variations. And that what influences, what goes up and down is the carbon dioxide level. So it's an important principle or fact to remember that at rest, it is the hypercapnic ventilatory drive which is more effective in controlling our respiration. Just to mention that sometimes, see, let's say someone has an obstruction. This is a small physiology point. But suppose someone has an obstruction in his breathing. Let's say a child has very large tonsils or very large adenoids, can't breathe properly. That's how they breathe, they struggle. What might happen is that because they are hypoventilating over a long period of time, they then develop chronic hypercapnia. Chronic hypercapnia, if it's there for many, many days, it actually, the chemoreceptors stop responding to. They adapt neurologically to this hypercapnia. So in that case, the person, that child or that person who has obstruction cannot respond to changes in the carbon dioxide levels as well as he or she was responding before the obstruction. In such patients, it is the oxygen drive which will drive their second to second changes. And this is very important. So that if you get, many of you become anesthetists in years to come, you might meet in theater, and when we are operating on children who have had chronic obstruction, we tell people don't use 100% oxygen because that sometimes may swamp their hypoxic ventilatory drive and the child goes into apnea. This you will understand more even when you do pathophysiology in your later years. Okay, I want us to take a small break because then we want to come back and discuss pH. Are there any questions that I can answer? Let me check the chat if there's any questions. Okay, I can see, yeah, people do a lot of chatting, but nothing here, no question. No problem. Let's take a 5-minute screen break. Walk away from your screens. Give your eyes rest. And then we'll come back. If there are questions on the chat, I'll answer them before we go to the next subsection. Okay, so we can restart. Let me just see if there are any questions. Hearing reflex only applicable at birth? No. I'm saying that it really it limits the hyperinflation of lungs, but in adults it seems to be more significant at high ventilation levels. Yeah, this is, there's a lot of inter-student conversations, so I don't know which ones are my questions. What is the effect of hypercapnia? Hypercapnia means the high amount of carbon dioxide. So hypercapnia, as far as respiration is concerned, is a respiratory stimulant. Yeah, so it causes a rise in respiratory rate. But hypercapnia results in blowing out carbon dioxide. Yeah, so hypercapnia is, if it blows out too much carbon dioxide, it is reducing the carbon dioxide in the body and then thereby causing a state of alkalosis. Explain the two drives. Very simple. High carbon dioxide drives respiration. That's called the hypercapnic drive. Low oxygen also drives respiration. That's hypoxic drive. Very simple. Okay, so those are the questions. Let's then look at pH. pH is is a distant third as a priority of the respiratory center, and oxygen being the first one, carbon dioxide being the second. Now, how does the respiratory system influence pH? Well, a fall in, first, let's look at some of the facts that a fall in pH causes a rise in ventilation. I showed you a graph earlier that showed that. And this is mainly via the peripheral chemoreceptors, but indirectly with the central chemoreceptors by detecting carbon dioxide. And in any disease that causes acidosis, yeah, we often quote diabetic ketoacidosis, but there are other disorders, of course. All of those will result in a ventilation, rise in ventilation. So what? So that rise in ventilation will then result in blowing off carbon dioxide, thereby blowing out, in effect, carbonic acid. And this may be a response to a low pH, or if it's the primary problem, if somebody is hyperventilating, then loss of that carbon dioxide may result in what is called alkalosis. In this case, it would be called respiratory alkalosis because it is due to a respiratory cause. This is the reaction that you have to keep in mind. And whenever you look at the pH and the respiratory system, remember to look at it from this perspective, that H plus, you can look at it from either side. Yeah, that in the blood, there is H plus and bicarbonate, which is in equilibrium with the weak acid, carbonic acid. Carbonic acid is in equilibrium with its two components, which is water and carbon dioxide. In this case, the carbon dioxide is being blown out by the lungs, so that if carbon dioxide is blown out and pushed, that way it will mop up the extra acid. That's why I keep on saying that blowing carbon dioxide, you're actually blowing out acid. If carbon dioxide rises, the reaction will be forced to the left, causing a rise in the amount of H plus ion, thereby a fall in the pH. So we can always look at the relationship of pH and respiration in the following manner, that either the effect of respiration on pH is that a rise in ventilation results to a fall in carbon dioxide, thereby causing a rise in pH. Saying that again, if you hyperventilate, you reduce carbon dioxide, that will cause blowing out of acid, thereby result in a higher pH. On the other hand, if the ventilation level falls, this will cause accumulation of carbon dioxide and thereby a fall in pH, because more carbon dioxide means more acid. And we've already looked at this in the previous slide, but the effect of pH on ventilation, that if the pH falls, there's a rise in ventilation. And the rise in ventilation then helps in blowing out that extra acid, which may be causing the fall in pH. The converse, my friends, you have to be very careful. A rise in pH will not cause a fall in respiratory rate to any extent where the oxygen delivery may be compromised. So you must never think that if there is an alkalotic state in the body, the response can be to stop breathing so that you can correct the alkalosis by accumulating carbon dioxide. Because the prime existence, the reason for existence of the respiratory system is to provide oxygen. It will never let that particular prerogative be compromised. Next, I would like to talk about the exercise and the respiratory system. It's a very nice little subtopic, which I really enjoy because it actually illustrates all the different types of control mechanisms that exist. Exercise is one of the most demanding states as far as respiration is concerned. And you find if you plot oxygen consumption over the ventilatory rate, you find that in severe exercise, moderate exercise, you can see it's almost going parallel. That as you exercise more, you not only have to ventilate more, but you are obviously consuming that oxygen. But this is one of my favorite graphs, which I'll just let me try to bring it to the center. Oops. This graph shows the ventilation rate at before, during, and after an exercise. So let's see what happens. One is resting, and respiratory rate, let's say, is going on at a particular rate, let's say 12 per minute. As soon as you begin exercise, the thought of exercise, as well as the first few movements you make, all of these will give feed-forward influence that immediately the respiratory rate would rise. This will be a feed-forward response. Then, as your exercise starts getting established, this slow rise to a level which is matching, where your ventilation rate matches the amount of oxygen which is being utilized, this will be a feedback response. You'll continuously go and reach a level where you have corrected for the new level. This will be your feedback response. This will be mainly the chemoreceptor responses. And then when you stop exercise, as soon as you stop exercising, the thought that you have stopped and the cessation of the muscular movements will immediately cause a fall in the respiratory rate. This is also a feed-forward response. It's from the proprioceptors and from the thought process that exercise has now stopped. And then there'll be a gradual negative feedback to bring back the respiratory rate to normal. Okay, please remember this, that this is how it works. Feed forward, feedback, feed forward, feedback. Will earn you many marks in due course. This is also a very nice, interesting graph that during exercise, you see if this is, exercise occurring, and we are looking at various parameters. You can see ventilation is steadily rising. So this is ventilation during the exercise. Look at the arterial oxygen. It hardly changes. And this is what I told you earlier, that our body is too good in controlling oxygen levels, maybe at minute levels, at hundreds of a millimeter of mercury, there may be changes. But in millimeters of mercury, we don't detect any change. The oxygen is kept constant. It's too tight. Yeah? Similarly, look at the arterial carbon dioxide. There are minor fluctuations, but they're almost simultaneously being adjusted by the rise in ventilation. So that in fact, with chronic exercise, your arterial carbon dioxide may actually fall, because now you are giving so much oxygen by that hyperventilation that you're blowing out too much carbon dioxide. So you find that with very strenuous exercise, you may actually find arterial oxygen is not changing, arterial oxygen level, but the arterial carbon dioxide level may actually fall. This is important, that the venous oxygen level, of course, may fall, because the extraction, I'm sure you covered this when you did blood gases, there's a certain amount of oxygen which is extracted from the blood that rises during exercise. So you find the oxygen level may actually fall during the venous level of oxygen may fall. And of course, the venous level of carbon dioxide rises. And here again, you see that in moderate exercise, there is hardly any change in arterial pH. But if there is chronic exercise, the pH level may fall as because of accumulation of acidic byproducts of metabolism. This is also an interesting graph comparing this, so I would advise you to try to understand all this. There are various influencing factors and theories to account for this. We say that there is cerebral cortical movements, influences the thought of exercise, as I told you, proprioceptors, the body temperature. As you exercise, your body temperature rises, and this may actually modulate the role of the controlling centers. And there may be small oscillations that I told you in tenths or hundreds of a millimeter of mercury. Those oscillations may occur, but at our normal measuring level, we cannot discuss. Yeah, we cannot detect any change. And actually, sometimes it's been postulated that the set point may actually change. That if we are doing chronic exercise, then our set point may change, that oxygen has to be at a particular level and carbon dioxide must be at a particular level. Okay, in fact, let me just move to the next slide. Yeah, I can quickly mention to you that this is pathophysiology, but I just mentioned briefly that since oxygen is our is the most required chemical by our body, anything that causes less amount of oxygen, there are various types of hypoxias that we talk about, where hypoxia is regarded as oxygen deficiency at the tissue level. And there's the first type of hypoxia where it is called hypoxic hypoxia. What this means is that there is lack of oxygen because of a primary lack of oxygen. Yeah, and what this means is that probably, for example, in altitude, high altitude, you have less oxygen, so you can't have more oxygen. So that is a hypoxic hypoxia. The second type of hypoxia is anemic hypoxia. Now, this is that you may have enough oxygen, but you don't have enough transport. So that if the person has less blood, then he cannot deliver that amount of oxygen to where it's required. So that is called anemic hypoxia. Interestingly enough, maybe carbon monoxide was mentioned to you when we were discussing hemoglobin, that carbon monoxide binds hemoglobin, preventing it from transporting oxygen. So that is also a type of anemic hypoxia. There's the third one called the stagnant hypoxia, where this is due to the lack of flow of blood, not of oxygen. So that when there's heart failure, the patient is not able to pump the oxygen, the blood full of oxygen around the body, then that may result in what is called stagnant hypoxia. These are ways of looking at why this respiratory system may fail. And finally, it is a histotoxic hypoxia that maybe everything is working, but you can't use that oxygen. So that is starving amidst plenty, and this is the oxidative poisoning, poisoning of the oxidative enzymes. Cyanide, for example, it poisons or it binds and paralyzes the cytochrome oxidase, and this then results in the person not able to utilize oxygen despite everything else being normal. So just remember that. Finally, I just want to mention to you there are many types of abnormal patterns of breathing. Earlier on, I had mentioned that, for example, in diabetic ketoacidosis, because of the acidotic state of the body, the patient may have hyperventilation, which has a name, in fact, it's called Kussmaul's breathing. And this is because of a primary acidosis in the body. Yeah. And there are other, I just want to mention two of them. One is called Cheyne-Stokes breathing, where the person has 10 to 20 seconds of total apnea. Then there is gradually an increasing tidal volume until he's hyperventilating, and then it stops again. So he starts with nothing and goes higher and higher and higher, over breathing, and then stops again. These are abnormal patterns and may happen with brain damage, circulatory disorders, so severe hypoxemia, where the feedback control is now getting paralyzed. There's another very interesting abnormal pattern of breathing, which is called Ondine's curse, which actually it's a long story, but basically it's based on a fairy tale, where a fairy curses someone who was unfaithful to this little fairy, and she actually curses the person that you will only breathe when you can think about breathing. You will only breathe when you are awake. As you know, our breathing is totally involuntary, but it has voluntary influence. Yeah. But when we sleep, we don't think. Most of the time, we don't even think about breathing. But there are people in whom the brainstem may get damaged and they can only breathe when they're awake. Obviously, then these people would need to be helped with mechanical ventilation. Okay, we are going at a very good rate, my friends. This actually concludes our control of respiration. To summarize, remember that we have looked at the control system, where we said the controlled variables are oxygen, carbon dioxide, and pH. What brings these about is our ventilatory system, where by ventilating, we deliver oxygen and we remove carbon dioxide. If we hyperventilate, we bring more oxygen, we remove more carbon dioxide. If we hypoventilate, carbon dioxide accumulates and oxygen falls. The levels of oxygen and carbon dioxide and pH are detected by sensors. We said the sensors are peripheral or central, and that information goes back to our controller. We looked at the medulla, lower pons and upper pons, and the controller can then influence the respiratory system either by hyperventilating or hypoventilating as necessary. And this is a classic feedback mechanism, and which is very tightly controlled. Our respiratory system does not allow oxygen to fall or carbon dioxide to rise in health. And then in addition to that, we have our the feed forward, where the controller may detect other influences, thought of exercise, temperature, pain, and proprioception, which then it will, for example, predict that there is exercise going to happen, and that compensate for that even before the demand rises. All right. So any questions, my friends? Let me see if there's any questions on the chat with regard to control of respiration. Because in fact, we are going to talk about, I think we're going to finish laryngeal physiology as well. Someone has said, Ondine's curse, is sleep apnea. No, sleep apnea, my friends, is something completely different. Sleep apnea is when there is, it's usually called obstructive sleep apnea. If someone has an obstruction, for example, very large tonsils or has a tumor, then because the act of breathing requires so much force, sometimes due to so much inspiratory effort, the respiratory system actually collapses, and for sometimes the person can't breathe. That is called obstructive sleep apnea. Hello, sir. I'm still confused on the concept of pH on ventilation. What is the effect of increase in pH on ventilation? Okay, what you have to understand is that what is the purpose of all this? We want to control our pH. And what can the respiratory system do to control the pH? If the pH falls, meaning there is too much H+, the respiratory system is stimulated, the ventilation rises, this blows off carbon dioxide, thereby blowing out acid, so our pH falls and corrects the fall in, pH rises, corrects the fall in pH. So if there is a primary fall in pH, the ventilation rises to get rid of acid, number one. Number two, if the pH rises, then the respiratory system really can't compensate because you can't stop breathing. Well, but you can't stop breathing because you have to deliver oxygen. So that hypoventilation is not an established method of compensating for high pH. Okay, I hope you understand that. Is the control variable in this respiratory control in the venous blood or arterial blood? Yeah, it is in the arterial blood. I think I said it severally. That's why it's called PaO2 and PaCO2. P is partial pressure, A is artery. Our control variable is controlled in the arterial blood. How does high ventilation cause fall in pH? It does not. That's a wrong question. High ventilation will cause blowing out of too much carbon dioxide and thereby causing a rise in pH because you are losing acid. Whenever you lose carbon dioxide, you're losing acid. So, Mr. Hamza, a high ventilation causes loss of carbon dioxide, which is loss of acid. That's why if someone hyperventilates, you may cause what is called respiratory alkalosis. Forcing functions, I think you've forgotten. Forcing function is a description of the influence the controller has on the controlled system. So in this case, our forcing functions are the increase or reduction of respiratory rate and depth and rhythm. Does pH also have effect on cellular respiration? Certainly, of course it does. That's the importance of pH. Later on, I think we'll have, you've already had the lectures on pH, or are they scheduled for later on? The importance of pH, that pH, H plus ion is a very active ion. It influences the reactions because of its denaturing effect on proteins, and most enzymes are proteinaceous in nature. So any metabolic function may be affected by pH. That's why our pH is so strictly controlled in the arterial blood. It is between 7.35 and 7.45. Is the control of respiration in athletes unique, and if so, how? Well, everything is subject to training, even holding your breath. If you hold your breath, I think I mentioned earlier, eventually the carbon dioxide rises and the oxygen falls, and you cannot keep on holding your breath. That's called breaking point. But you can train yourself. There are people who are called free divers, for example. Free diving means you go underwater without any oxygen, and then you stay down as deep for as long and as deep as you can. Now, a normal person can't even hold the breath for more than 30, 40 seconds, really. But you can train. People have trained themselves to even hold their breath for as much as 2.5 to 3 minutes. And what happens is that in such people, their hemoglobin level has gone higher. Their myoglobin level has gone higher. That is why all the mammals who are underwater mammals, such as these whales and dolphins, all of these have special myoglobin, which retains a lot of oxygen. Whales, when they come up, they take a breath. Their nose is on top of their head. Yeah. That the one they say the whale blows that what is blowing is their nose. And that they take a lot of air, but they have special myoglobin which stores the oxygen, not hemoglobin, myoglobin, in the skeletal muscles. And then they can go down and stay down for hours. Oh, what is feed-forward control again? Feed-forward means forward planning. In respiratory system, the feed-forward is occurring before the demand for ventilatory rate change rises. So, for example, when you think of exercise or when you start exercise, the immediate proprioceptors, the immediate movement through the proprioceptors tells the respiratory system that we need to start hyperventilating. The question here is saying that, I have just answered it, that training has a lot to do with this, yeah? So that when you train, when your respiratory capacities change, your heart, cardiovascular system often go together. Muscles also will change, the vascularity of your muscles will change. So yes, all these effects are affected by conditioning. Yeah? How do we correct hyperventilation? I didn't want to go too much into that, but if, for example, hyperventilation may be hysterical, that someone is either too excited or too sad. If you get, suddenly you realize you've got 100% in something, and or you've passed your exams, or someone dear to you has just returned from road, you start hyperventilating, or you can be very angry and you hyperventilate. That can result in respiratory alkalosis. And later on, when we discuss pathophysiology, there are ways and means to conquer this. But one of the mechanisms is that in a person who's hyperventilating, and you need to calm him down. You ask him to breathe into a paper bag so that he breathes back some of his carbon dioxide and does not cause respiratory alkalosis. How does the thought of exercise increase the rate of respiration? I think I've mentioned this severally now, but this input from the motor cortex to the respiratory center. So when we think about exercise, there are neurons which actually tell the respiratory center that exercise may start. Gordon Novino is again going to the same point, which I think again you're making the same error. Yes, a rise in ventilation, if beyond a certain limit, may result to a rise in pH of the body. But a rise in pH will not cause a fall in ventilation, because ventilation is important for delivering oxygen. Please don't make this mistake. I don't know whether you meant it as a joke. Your chat is even amongst yourselves. I don't know which ones are. No. Someone is saying recap respiratory acidosis, alkalosis. No. Today is not the time for that. We will discuss pH another time. I was looking at only the relationship between this, but since someone has asked, let me just mention it. So if someone hyperventilates, and this may happen not only with hysteria, but it can also happen during anesthesia, where a person is, when someone is under anesthetic, the person the anesthetist has to breathe for the patient, or has to attach him to a machine. That machine may overbreathe. That may cause hyperventilation. In this case, that person may get respiratory alkalosis. On the other hand, if someone hypoventilates, if someone has an obstruction or has got an injury, the chest can't move, or has brain injury, which the respiratory center is causing hypoventilation, then he may hypoventilate, resulting in accumulation of carbon dioxide, and hence that situation is called respiratory acidosis. Zamzam Muhammad is asking, why do we need to increase our breathing rate during exercise? Wow. I'm rather shocked at this question, but during exercise, Zamzam, we need to give more oxygen to our muscles. Danielle is saying, why do we associate pH with carbon dioxide, and yet pH deals mostly with hydrogen ions? Well, I think then you have missed the whole point. Here it is. Where is that equation? This equation, can you see this equation? This is a very important equation in the body. We cannot live without bicarbonate. We can't, and we certainly can't live without enough carbon dioxide. This is in our blood. So that carbon dioxide plus water gives carbonic acid, which dissociates to bicarbonate and H+. This is constantly in equilibrium. So if carbon dioxide rises, it pushes the equation that way to give you rise in H+, which is a fall in pH. If carbon dioxide is blown out, the opposite effect. Okay. I mentioned that bag in hyperventilation. Yeah, the reason is that you can deliver oxygen, carbon dioxide. I've actually done this once when I was not yet an ENT surgeon, many centuries ago. Some of these, I think I can't see any more questions. So let's take another 5-minute short, in fact, 3-minute screen break. Then I come back and I'm going to talk to you about laryngeal physiology, a very short lecture. And I think your class rep has said that people want to take a break at 4:15. So we'll finish by that time. In fact, we have gone at a very good rate. So we'll finish. So take a 3-4 minute break. just to refresh your eyes. Section, and we have put it in the curriculum since many years because many people never understand why we have a larynx. And if I were to pose this question to many of you now, many people say a larynx exists for us to speak, and that is right, but wrong at the same time, because that's not why the larynx evolved. Out of all the mammals that have larynxes, we are the only ones who speak. So obviously that cannot be the only function of the larynx. So this will help us to understand why we have a larynx. So to start with, what is the larynx? The larynx is the junction where the nasal cavity and the pharynx divides into the lower respiratory tract and the gastrointestinal tract. And the larynx is basically starts at what we call the laryngopharynx. As you know, the pharynx is divided into nasopharynx, oropharynx, and laryngopharynx. And there then behind the posterior to the larynx is the esophagus, and the larynx then becomes the start of what is exclusively the respiratory tract. Up to then, these are common. Yeah, the oral tract is both for eating, drinking, and breathing. Yes, the nose is used mainly for respiration, but also for the sense of smell. But after this, the respiratory tract is now exclusively for respiration. The structure of the larynx, my friends, it is various cartilages. So if you look at it anteriorly, the largest cartilage, which is obvious, and which it gives you the so-called prominence of the larynx, which is either in men called the Adam's apple, yeah, and it doesn't exist in pre-adolescent boys. When their testosterone rises, it causes the cartilage to have this shape, and they get this. That's when the voice breaks, and they have this what is called Adam's apple, and the ladies just get left with the Eve's strawberry, and then the epiglottis, which is also a flap-like cartilaginous structure. Then you have the cricoid cartilage. These three large cartilages, this is the anterior view, and this is the posterior view, where you have the epiglottis, the thyroid cartilage, and the cricoid cartilage. The cricoid cartilage, in fact, is the only cartilage that is a complete ring. All the other cartilages are not complete rings, they are C-shaped. Yeah, this cricoid cartilage, in fact, is the thickest cartilage, not the biggest, but the thickest cartilage. And that is what gives the upper larynx the patency. Yeah. In between the cartilages, we have various ligaments which convert that into a tube, and muscles as well. So that when we look into somebody's throat, we're using either endoscopes or laryngeal mirrors. This is what you see, that these are the vocal cords. This is the cavity of the, it's called the rhima glottidis. And these are the aryepiglottic folds where the arytenoid small cartilages are covered by mucous membrane. If you look at it as a coronal section, you'll see that the vocal cords are the end of this vocal ligament there. And you also have what are called the false vocal cords, which are called also vestibular folds. So these are called the vocal folds and called the vestibular folds. The larynx has many basic actions which will lead us to its functions. The vocal cords may abduct. Abduct means that they may go from a closed position, if you can see my picture, to an open position. That is called abduction. So we are closed and you move away, that is called abduction. So the larynx may open itself. Yeah, that's abduction. Then you may have adduction, where you have closure. From an open position, you come back to a closed position. Adduction. And then you have this closure is not only at the level of the vocal cords, but the vocal folds, the vestibular folds, also called the false vocal cord, which I showed you in the previous diagram, and the aryepiglottic folds. So in this diagram, the vocal folds, the vestibular folds, and the aryepiglottic folds. All of these, vocal, vestibular, aryepiglottic. Aryepiglottic means from the arytenoid cartilage to the epiglottis. Yeah. So in this case, the vocal fold will be this one, the vestibular fold will be this one, and the aryepiglottic folds will be this one here. Yeah, it's shown partly because it's a coronal section. This then close the larynx completely. One thing I'll tell you, and this is a concept which many people are taught in primary school, which is unfortunately incorrect. The epiglottis doesn't come and close like a trap door. It's not like this. Yeah. Yes, it moves downwards and protects the opening, but the epiglottis itself does not close. It's not a lid. Yeah, it used to be thought it's a lid, but it's not. Yeah, the larynx closes by itself, and the epiglottis comes so that it directs, especially fluid on the sides, so that fluid doesn't go on into the larynx. Yeah. So this closure, you can see, is a very important function of the larynx. Yeah? The vocal folds can change in tension and change in the size of the rima glottidis, which means that the vocal cords, you can have part of them vibrating or a larger portion of them vibrating. This gives you an idea. So if this is the glottis, so this is now the other way around, where this is the epiglottis, this is the aryepiglottic folds. Here is our vocal fold. Just on top of it, you have the vestibular fold, which is the false vocal cord. So this 1, 2, 3 folds have the ability to close. And the epiglottis has the ability to move over and direct fluid away from the opening of the larynx. With that, then we come that, okay, now that we know the movements, there are cartilages, there are ligaments and muscles. By the way, this is, I'm not going into detail. You will learn some of these details in anatomy. What we are interested in is that you have a tube, it has the ability to close, ability to open, ability to change its tension and length of the vocal cords. So what can the larynx then do? Why do we have a larynx? The functions of the larynx are in this order, and in fact, a phonation comes a distant fourth. The first function of the larynx is to be a conduit for breathing. So it allows breathing to take place. It is a conductor of the air, and because it can change its aperture, it causes turbulence. This turbulence allows mixing of the air as the air passes through the larynx onto the trachea. But that could have been done even without any of the structures that I've mentioned. The function of the larynx, my friends, is a sphincteric protective function. Yeah, the sphincteric protective function is that whenever there is a chance of any foreign material coming into the larynx closes tight. 3 sphincters: focal fold, vestibular fold, and the aryepiglottic folds. All of them close and thereby protect the lower respiratory tract. In fact, that is the raison d'être of the larynx. The sphincteric closure of the larynx protects the lower respiratory tract. That protection then is also used, or that effect is also used for the purpose of effort. How do we say? I mean, many of you might be watching sports, and there's recently one of the great athletes that we have ever known. She retired from tennis. Her name was Serena Williams. And if you don't know her, I don't know where you've been living for the past 20 years, but Serena Williams was one of the top lady tennis players, but she had a very famous grunt. When she plays the shots, she used to always and I wonder whether you've ever wondered that why do people grunt when they're making an effort? When you're lifting something heavy, you might say, or whenever you want to make an effort, there's a little grunt that comes out. That grunt is not by itself a manifestation of effort. But what happens is that because our shoulder girdle, and no doubt you've learned this in anatomy, the shoulder girdle is so flexible. To stabilize the shoulder girdle, to make the chest as stiff as possible when any extra effort has to be made, the larynx closes. The larynx closes, and against the closed larynx, you make an expulsive effort so that the chest becomes tight. And it is during that closing the larynx and making that expulsive, the effort, that you get this grunt. Excuse me. And that helps in effort. And then we will talk about what happens in phonation a bit later. Phonation is the production of sound, and speaking is then a byproduct of phonation. So let me go into a bit more detail of each of these. I've already mentioned them in general, but the conduction function of the larynx, in inspiration, the larynx abducts. So it opens up, but not completely. It opens up to a certain point where it still allows for turbulence to occur. And this opening up is active, first of all, due to the laryngeal muscle activity by itself. And secondly, it is passive because when one breathes in, the trachea is pulled downwards by the stretching of the chest, and that causes some passive opening of the larynx. In expiration, the vocal cords come back a little bit, and this increases the respiratory resistance and prolongs expiration. If you remember, expiration is largely passive at rest, and expiration is always longer than inspiration. You inspire and expiration, and the rest period is longer. And that part of the reason why it is longer is because there is a respiratory resistance because of the closure, slight closure, not complete, of the vocal cords. This diagram shows you what happens. The glottis opens, the V becomes larger. When it's closed, it's almost completely closed. This is at midpoint, part abduction, part adduction. The protective action, I've already mentioned to you that the sphincteric action at 3 levels, the level of the vocal cords, level of the vestibular cords, also known as the false vocal cords, and the aryepiglottic folds, all of those close the larynx to protect the lower respiratory tract from any noxious substance or stimulation. Even cold air can cause closure. Food, water, any foreign substance, dust in the air, may the larynx protect itself by closing so that the lower respiratory tract is unharmed. Each time we eat, every time we swallow, the larynx has to close. That closure prevents the food bolus from going into the respiratory tract, so that everything closes. The epiglottis does fall backwards, but it's not falling back like a lid. It's just falling back like a chute, so that allows the food to slip over the larynx and right into the esophagus, which is posterior to the larynx. So every time we swallow, and we swallow 10 to 12 times in a minute, we subconsciously swallow. We don't even remember that we are swallowing. We don't think about it. So that is very important to remember. The second part of the protection, which I didn't mention earlier, although I mentioned in passing, are the various reflexes that involve the larynx. The first one is the cuff reflex. The cuff reflex is from the lower respiratory tract. If there is some dust that reaches, or let's say a bit of saliva, manages to crawl into the larynx or trachea, or some mucus gets stuck, we then have the cuff reflex. What is the cuff reflex? We take a small intake of breath, close the larynx, and then open it suddenly. That is just like that grunt which I mentioned, which I'm going to mention more just now. But that sudden opening of the larynx expels the noxious substance from the deeper part outwards. Yeah. If there is a lot of stimulation, the larynx can in fact go into what is called laryngospasm, where the normal physiology becomes dangerous to you. If a person goes into a laryngospasm, that in fact results in possible apnea, so that the person may actually suffer. But most of the time, this doesn't happen under this physiological circumstances. The hiccup, a hiccup which is a sudden intake of breath and with the larynx partly closed, partly open, so you get that hic sound. That hiccup is actually not brought about by stimulation in the larynx. It's brought about by stimulation in the lower end of the esophagus. So if you have a very dry meal, certain certain dry foods may irritate, then you get this sudden input of breath. And people have never really worked out what is the physiological importance of a hiccup. And the jury is still out on that. The yawn also involves the larynx, where the person has a long inspiratory reflex, and this often is thought to be more of a communication reflex for mammals, so that when they are tired or there is hypoxia, you take a deep breath inside to offset the hypoxia, but it's more like a communal signal. It's been found that when one person yawns, it is strangely infective to the person next to him. He feels like yawning also. And this is thought to be more of a mammalian signal rather than a pure physiological reflex. Effort, I mentioned to you about the famous Serena grunt, but effort can be of three types, where the first one is expulsive. Whenever one wants to remove something from the body, and this could be fluid, flatus, feces, or fetus, yeah, all Fs. Whenever you want to remove this from your body, you will need expulsive effort. And that expulsive effort is done in the same way as I mentioned earlier, where the larynx closes, you stabilize your shoulder and your chest wall, and then you can exert maximum force by contracting your muscles, including your abdominal muscles, especially when you're involved in expelling flatus or feces or fetus. Yeah, childbirth involves a lot of expulsive effort by the mother. If you've ever witnessed one, or you may have seen it in films, or you should go to our obstetric wards in due courses and see how it happens. It requires a lot of effort, expulsive effort. The second effort is propulsive, which I mentioned to you earlier, the cough, where you have this compression phase and sudden expiration, and you are actually removing material, you're propelling that material out of the body. And supportive, I've already mentioned to you that this helps to exert physical effort so that you stabilize your chest and shoulder girdle so that you can exert more muscular effort. So three types of effort: expulsive, propulsive, and supportive. Finally, we come to phonation. Now, phonation, you see, it's a byproduct of the laryngeal function. It was later on in the evolution of the species that larynx was used to produce sound. And first of all, producing sound only is phonation, and making that phonation into intelligible speech is a very, very higher function, which only us humans have. So to phonate, this is a very big topic, but I'm summarizing it for you. To phonate, to produce sound, you need three requirements. One, there has to be airflow. So our expiratory, we use expiration for talking. Horses neigh, the neighing of a horse, N-E-I-G-H, the neighing of a horse is inspiratory. So We can also talk by inspiration. We can talk, for example, I can say the next sentence, by inspirating. So I said by inspirating, by taking the breath inside, but it's not clear, yeah, because we're not used to it. But people train themselves to speak just for entertainment purposes. So airflow, we use our expiration to create that airflow. If airflow is low, we speak softly. If airflow is higher, the sound produces louder. Secondly, you need a vibrator. The vibrator in this case starts with the larynx. The larynx, the vocal cords, actually the mucosa vibrates. And this, if you go to YouTube, you can look at many slow motion videos of the vocal mucosa. When the air goes through them at slow motion, the mucosa vibrates, and that creates vibration in the air, which we perceive as sound. As soon as that vibration occurs, then the resonation of that sound, larynx, oral, nasal cavity, our sinuses, our skull, produces a unique sound. That is why every human sounds different, because no human can be absolutely identical. And because our resonation is different, there may be similar sounding people. That's why family members sometimes sound like each other. Sons may sound like their fathers, and daughters may sound like their sisters or their mothers. And that is because their structures are similar. But if you analyze the sound, there will still be some difference, just like fingerprints. You can have voice recognition software. That's why you can have voice recognition software, just like you have face recognition. After that, you have the articulators, where articulators change the basic sound. Like if I stand here and say, that is a basic sound. But by the use of the pharynx, palate, tongue, teeth, lips, and the nasal cavity, that basic sound gets changed. So that we change into, let me just, I will demonstrate to you a bit later on how the articulators change. So this just tells us that, yes, here we are, our vibration is here, resonance is here, and then our articulators are where the sound is going to pass from the palate, the tongue, the teeth, the lips, and the nose. I've already mentioned to you that the airflow, if you increase the rate and pressure, the loudness and sustenance of sound changes. And this is, if you look at a cross section, this is how vibrations occur. That if the vocal cords are closed, then when the air pressure rises, a little bit passes through, then the vocal cords close again. And so the gradual opening and closing of the vocal cords is what results in the vibration of the in the air. Our vibrator can be changed in terms of its tension and its length, just like a guitar string. Now, those of you perhaps play guitar, when there's a shorter string, the sound is a higher frequency. Similarly, the vocal cords may become shorter, and you use only part of it to vibrate, you get a higher note. But you can also do that by changing the tension. So those of you, again, if you have a stringed instrument, if you change the tension of, so that the string is at a lower tension, it will be tongue, and if you change, it will be tongue, it will go higher. That both these effects are utilized at the larynx to change the frequency of sound emitted from our larynx. Yeah, I've already mentioned the vibration, and then once the sound reaches our articulators, that's when we really become human. Then we change sounds to either consonants or into the vowel sounds. Now, for example, the vowel sounds are simply a change in the shape of the mouth. So look, if you can see what I'm doing, you see I, O. All I've done is change the shape of my mouth, and all the sounds are being emitted. I, O. That is the way the articulation of the vowels is being done. Similarly, the palate changes the sound, and for example, k and q are from the palate. In English, k and q almost are equivalent, but in certain languages, Arabic, for example, k and q is very different. K is more, the q, k is very wet. It's from the deep part of the soft palate, and k is more dry and superficial. Similarly, the tongue is used to make sounds like t, r, that's a vibration, l, l, and d. All these sounds are made by the tongue. Yeah, the teeth are used to make s and z. Yeah, and then we use our lips for the ones that blow the sound. P, b, v, w. Those of you who are singers or who delve into the world of singing, you are taught how to soften your b, v, and w so that it doesn't hit the mic too much. Because if you say b, it's a big burst of energy. Yeah. Then the nose is used for n and ma. Yeah. That's why if you close your nose, and n and ma almost sound the same. Yeah. But if it's open, n and ma sound different. All of this are subject to training, saliva, musculature. The more you train, the more clear you can become. So remember, phonation is a byproduct of the basic function of the larynx. It is not the main function. Of course, in us, it is vital to be able to use our language appropriately. Finally, remember the prime reason for existence for the larynx is sphincteric and protective actions. Phonation is a later developed use. So I think that's 4 o'clock. I think some people wanted to take a break at 4. So I think we have in fact finished control and the larynx. So in fact, we can call it a day. I'll answer any questions. And tomorrow you can have self-study. You can go and read on your own in that 1 hour that was scheduled for me. So let me just see if there is any question. No, I think people are just talking amongst themselves. Right. Any questions? If there are no questions, Miss Kelsey, do I have your permission to sign off? Everyone happy? I will send you my series of these slides in PDF. In fact, there'll be even more slides than what my topics were only, of course, the ones I gave you, but my whole lecture slides on respiration, I will share with you. Then you can use this as a part of your reference. Yeah. Okay, fine. So have a good day, everyone. God bless. And then we will meet in a few days' time.
Thank you.
Thank you.